Today we are reviewing intracranial hemorrhage on CT brain, and the aim is not just to memorize appearances. The aim is to develop a pattern recognition approach. When you see hyperdense blood on a non-contrast CT, pause and ask 4 things. Where is the blood? What shape does it make? What is the likely cause? And most importantly, are there dangerous complications like mass effect, midline shift, hydrocephalus, herniation, or intraventricular extension? Start with epidural hematoma. This is an extraaxial bleed between the skull and dura. On CT, it is classically biconvex or lens-shaped because it is limited by suture lines. It is usually traumatic, and the classic vessel is the middle meningeal artery. Clinically, we talk about a lucid interval, but do not rely on it. It is classic, not mandatory. Now compare that with subdural hematoma. This is also extraaxial, but it lies between the dura and arachnoid. Because it spreads over the brain surface, it forms a crescent shape. Unlike epidural hematoma, it can cross sutures, but it is limited by dural reflections such as the falx and tentorium. The usual mechanism is tearing of bridging veins, so always think of elderly patients, cerebral atrophy, alcohol use, falls, and anticoagulation. Another important point in subdural hematoma is timing. Acute blood is usually hyperdense, subacute blood may become isodense, and chronic subdural hematoma is often hypodense or mixed density, so the CT appearance can change with time. Subarachnoid hemorrhage has a different pattern. The blood is not lens-shaped or crescentic. Instead, it fills the sulci, fissures, and basal cisterns. Clinically, the classic presentation is a sudden thunderclap headache, often with vomiting, neck stiffness, photophobia, or reduced consciousness. Trauma can cause subarachnoid hemorrhage, but if it is spontaneous, think of a ruptured aneurysm until proven otherwise. Also, look carefully for hydrocephalus. Intracerebral hemorrhage means the blood is inside the brain parenchyma. Here, the location is extremely helpful. A deep hemorrhage in the basal ganglia, thalamus, pons, or cerebellum suggests hypertensive small vessel disease. A lobar hemorrhage, especially in an older patient, should make you think of cerebral amyloid angiopathy, but also consider anticoagulation, vascular malformation, tumor, trauma, or hemorrhagic transformation of an ischemic stroke. If blood extends into the ventricles, that is intraventricular hemorrhage. This matters because blood can obstruct CSF flow and cause acute hydrocephalus. So IVH is not just an imaging finding. It usually means a more severe bleed and a higher risk of clinical deterioration. So keep the pattern simple. Lens-shaped means think epidural. Crescent-shaped means think subdural. Blood in sulci and basal cisterns means subarachnoid hemorrhage. Blood inside the brain tissue means intracerebral hemorrhage. Blood inside the ventricles means intraventricular hemorrhage and hydrocephalus risk. But a good CT interpretation should never stop at naming the bleed. Always comment on mass effect, midline shift, effaced basal cisterns, hydrocephalus, ventricular extension, herniation risk, fracture, and any possible underlying structural lesion. The final message is this: shape helps identify the bleed, location suggests the cause, and complications decide the urgency.